closer.
My name is Jonathan Ramsay. My address is number 5 Southley Road in Datchet. I am a consultant urologist. I work within Imperial, principally at the Hammersmith Hospital. I also work at the West Middlesex and at the Chelsea in Westminster.
If you turn, please, there should be a bundle in front of you marked Volume 1. They have unfortunately got somewhat out of order.
It's a terrible thing to fail at the first jump.
It's not your failure.
Wait a minute.
Page 7, if you would. That should be an email from you.
Correct.
Can you please confirm that the contents are true to the best of your knowledge and understanding, and that you wish to stand through evidence for the Commission?
Correct, and I do.
What I'd like to ask you about first is your role in shaping a healthier future. Can you explain to the Commission what your involvement and remit was?
Indeed. So I represented the Royal College of Surgeons of England to give advice principally about emergency surgical provision within the sector.
And when were you last? When were you last involved in the board in that role?
Approximately 6 months ago.
And at that point, were you broadly supportive of the aims of shaping a healthier future?
So the aim, I must preface that remark by saying that I need to stick to surgery. And I am well aware, particularly having listened with great interest to the last witness, that in fact surgery, and particularly emergency surgery, is a very small part of total healthcare provision. It sometimes gets an unequal share of the action because it's exciting in the true sense of the word, it's expensive, and the people who talk about it often talk quite loudly and forcefully. But nonetheless, it is a small component of the whole. So my role was relatively small and narrow, but did concern a very important part, nonetheless, of healthcare provision in terms of quality.
So limited to the area that you were directly involved with, were you, as far as that area is concerned, supportive of the reconfiguration and the aims that were being promulgated in this programme?
Absolutely.
And at that time, was it your view that the reduction, and you may say this is outside your remit to comment upon, that the proposed reduction from 9 major hospitals with all services to 5 major hospitals was a proper approach or not?
I would, for the purpose of providing the quality of emergency surgery, principally because of the standards that surround such provision. Those standards were then being developed by Healthcare for London, and I worked with them as one of the team that looked at appropriate standards for emergency surgery.
Did you at the time think that there could have been other equally legitimate solutions to that proposed?
So if we talk about what those standards are, the solutions become clearer. The most important thing is for an acutely ill surgical patient, and indeed other patients, to have the benefit of a consultant opinion within a reasonable time of their admission, which was set to be 12 hours. And surrounding that admission, there needs to be the sort of service that we would all want and expect in terms of radiology.
Can I ask you to pause and press the button so you can be heard? I'm so sorry.
In terms of radiology, in terms of interventional radiology, And of course, this requires a lot of personnel and equipment to be co-located. And the only solution to providing this bit of medical care, this bit of emergency care, must be for more centralisation. And after all, we're not talking about Suffolk or East Anglia here. We're talking about a relatively small geographical area. Now, when we make these pieces of advice, and this was not just the Royal College of Surgeons, but Healthcare for London, and those stipulations, those standards, were surprisingly congruent between those two bodies, one has to be aware of the unintended consequences of making such statements. Certainly, however, such a reduction to 5 centres in terms of acute surgery could only be the right thing to do.
And that remains your view?
That remains my view.
Now, you say in your document that the reconfiguration board considered sites but assumed that the trust responsible for the reconfigured site would manage the diverted cases on their remaining facilities.
Correct.
I wonder if we can break that down a bit and you can help us with this. What sites did the board consider and what, if any, conclusions did it reach?
So it considered the imperial sites as being one. So that and I'm talking for emergency surgery, in terms of emergency surgery, it was considered that Imperial, responsible for those 3 sites, would make suitable arrangements to deal with the emergency surgical workload. It was assumed, most probably, in the majority of cases, on one of those sites, because it was assumed particularly that Hammersmith, which was not an emergency surgical site at the time, would certainly not continue as such. So the board's deliberations assumed that policy for Imperial, not dissimilar from what had happened with the North West London hospitals, and they regarded Northwick Park and Hillingdon as being outside a networking capability, because the distances were too far to allow an easy cooperation. So within the centre, Imperial was one unit, North West London Hospitals was another unit, Chelsea and Westminster and West Middlesex were separate, and at that stage were considered as being apart.
So that was the assumption, that's what the board considered. Are you able to help with why the board was confident in that assumption?
Could I ask for voices to be kept up a bit? Sorry.
Yes, I'm so sorry.
Why was it the board felt that it could make those assumptions could be relied upon? That's if I would get that right.
I can't really answer why they thought they could be relied upon, but it was not an unreasonable assumption, being in the room at the time, to imagine that one of the sites within Imperial, particularly that one designated as a major trauma centre, would also be entirely competent to deal with emergency surgery.
Were there any assurances given by any trust members who were present that that would be the case?
I can't answer you that because I wasn't at every meeting.
Were you aware of any assurances given?
No.
Was it explored, and you may not be able to answer this, was it explored with those members of the trust who were present, that those assurances might not be correct, that it might not be the case in fact?
There was a part of the clinical board, the group within it, who considered emergency services as a general issue, not just surgery. I wasn't party to that group, but I think it is my impression and my view that they took that matter seriously. Where their advices came from, I am not sure.
Are you aware of whether or not any specific assurances were given by Imperial in respect of the removal of acute services from Charing Cross Hospital?
I am not.
Are you aware if there was any evidence provided by Imperial to underpin the assumption that St Mary's would be able to accommodate all of the cases which were coming in their direction?
I am not aware of such evidence.
Now, you set out in your short paper a number of changes that have occurred since your involvement which have impacted on your thinking. Now, could you expand, please, on what you say has changed, first of all, with regard to emergency surgical volumes? Do we know why the increase, and do we know what the size is?
We know neither of those things. We can adduce that this has happened by an increased demand for level 2 and level 3 care, that is what is also known as high dependency HDU and intensive care, that's level 2 and level 3. So we can adduce that. We can adduce it from attendances in A&E, although it is quite difficult to separate acute surgical attendances which relate to abdominal surgery from the others. Quite difficult in terms of coding. I believe that currently, at the present time, the board is trying to look at current evidence, contemporaneous evidence, for the number of acute abdominal surgical cases that are entering the hospitals in the sector. But you have to do that by HES codes, and that, as I say, is not easy. At the present time, the College of Surgeons of England is doing a laparotomy audit, which may throw some light on the question that you've just answered, for there is a suspicion that this type of work, this type of surgical emergency, is increasing nationally.
That's not something you would, I think you use the word suspicion carefully. It's no more than that at the moment.
It is no more than that.
Complexity and comorbidity, again, that's another area you identify. Again, is it increasing? And if so, do we know why and by how much?
We know that it is increasing. We think we know why. Of course, that's the trouble with all doctors. As they get more senior, we're almost sure we know why, but we think we know why, and that is because the population ages and techniques do improve, and therefore you tend to operate on more patients.
And is there any, are you able to assist with any degree about the scope, size?
So you can, well, you can reduce this within specialties. So for example, if you look at my own specialty, the number of people, the number of patients, mostly elderly, who can undergo a very major intervention to have their bladder removed, for example, is increasing significantly. By how much? Over the last years, over the last 3 years, by approximately 10%.
Now you also talk about capacity in the region being saturated. Can you help us with whether this was foreseeable, and if it was, why it was not foreseen?
Yes. It's the Donald Rumsfeld question. Foreseeing the unforeseeable.
Yes.
So I think that the board attempted to come to the right judgments about acute surgical care, particularly in terms of those patients who might need the level 2 and the level 3 care. Because within the board there was a separate group who looked at intensive care and looked very, very closely to see what would happen if you moved intensive care facilities around the region and took some of them out, and what would be required to be re-provided, to be increased on the remaining sites. And this was a very careful piece of work. It was orchestrated by intensivists, and these weren't people who had any other interest than to get intensive care right. So these were intensivists from the existing trusts. the expenditure in order to relocate and recreate these facilities was quite considerable. And they built in a little bit of extra capacity for this new network. So I think that that was a right-minded piece of work. I don't think contemporaneously, I went to some of their meetings, that they were underestimating, because all of those clinicians, frontline clinicians, know that if you underprovide HDU care for acute surgery, then you end up in a far worse place. It's more expensive, the outcomes are worse, it's a disaster. So that piece of work was right-minded. I think it was based upon correct fact and probably a correct prediction. But once again, we're talking about this work having been completed about 18 months ago.
And since then, I suppose the question is, but then?
Well, since then, I think if you wanted to update that particular evidence, a good place to go would be the intensivists who made those predictions. That would give a fairly accurate view of the probable increase in acute surgical activity over the last 3 years.
And so the conclusion that you then draw, that at the moment capacity requires all of the imperial sites.
In order to maintain the elective, the major elective surgery and the emergency activity, it is difficult to imagine that the facilities that are currently used will not need to be continue to be utilised to their full.
If the reconfiguration continues and the proposed changes take place, what's the likely effect on the areas you've talked about?
So it is clear that what is currently available, I'm talking about acute surgery. I'm so sorry, I'm trying to look at the questionnaire. So it is clear that the currently utilised facilities would need to be provided at the same level, indeed at a greater level, on the new reconfigured sites.
So finally, what should happen now?
So what is happening, well, I can tell you, although I am representing the College of Surgeons, and I must add that I have not been harassed by Imperial. I don't think I will be. But currently I can bring some news from at least one of the Imperial sites, which is that I'm pleased to report that there are currently adverts for...
Can I ask if you're going to report something? If you can perhaps keep your voice up, because I'm strange to hear something
okay,
that seems good news.
So that a bit of good news, that there are currently adverts which I have seen for the appointment of 3 new general abdominal surgeons at Imperial. This increases the numbers to a level at which I believe that the very important standards that we started with should be possible. I should add, of course, that when I visited many of the trusts in London for Healthcare for London, as it was then called, none of those trusts were meeting those standards. So there is a London-wide problem which primarily requires to be addressed by the appointment, I know all senior doctors say this, by the appointment of more of our tribe, but that is nonetheless a true statement. And I'm pleased to report that currently there are those 3 advertisements extant.
Thank you. I have no further questions. If you won't have any questions from the commissioners.
Yes, thank you very much. The question I have to ask may be too compendious for you to answer in the time you have available, but I feel compelled to ask it nevertheless so that we can start the analysis. And it's this, that, and it ties in with what you just said about none of the trusts that you examined in the North West London area achieve the proposed, and that's how you've written it down in here, emergency standards. Now, I want to take this in stages. Before the proposed standards, obviously there was another standard. Because otherwise you wouldn't be talking about proposed standards, I don't think. Now, if there's a difference, what is the difference? Secondly, to what extent did the trust fail to meet the proposed standards? In other words, was it all the same? Because you mentioned particularly at the beginning of your evidence on-site consultants and radiology. Now, are those the standards that you're talking about, or is there much more that I'm missing here?
Okay.
So, do you see the thrust of the question?
I see precisely. So it is, well, I think I do, but put me right if I don't. The first thing to say is that I didn't say that it was most of the trusts in North West London. This was most of the trusts in London.
Yes.
It was London-wide. And secondly, it is right for me to say that prior to the attempts, the congruent attempts of the College of Surgeons of England and Healthcare for London as it then was, prior to their attempts to derive standards, there were no standards. So this is the first proposition, the first and only proposition of standards. This arose because of a report by our friends in journalism about the dangers of entering a London hospital, a hospital in London, over the weekend with an acute surgical condition. And I'm sure you will remember that this was 5 or 6 years ago. And Healthcare for London and the College of Surgeons picked up on this and responded, and hence those proposals were the first proposals.
Well, I have a supplementary, needless to say, and that is, instead of reducing sites, was it considered by the board there's a possibility of raising all the hospitals to the same standard?
A very good supplementary question. I think all doctors, all surgeons, and particularly those groups of us who are in Suffolk and East Anglia, would clearly take that view. The view that you just increase the staff, whatever. But of course, when you are only dealing with a population of perhaps 200,000, catchment population, maybe 180,000, as is typically the case in North West London, if you're going to meet the emergency standards and have sufficient numbers of consultant staff, both radiologists and surgeons, and subspecialty surgeons, which was interestingly alluded to by the previous witness, then you don't have anything for them to do that isn't emergency in their elective lives. Now, this is partially a problem because of subspecialization. And this is fundamental, actually. This supplemental question is fundamental. When I started at the West Middlesex Hospital, there were 5 totipotential surgeons. And so I was appointed as a urologist and a general surgeon. The general surgeon, one of the other general surgeons, happened to do most of the breast work, but his colleagues did this as well. The vascular surgeon did most of the vascular surgery, but also the general surgery. So with a catchment of a couple of 100,000 around the West Middlesex, 5 surgeons produced a unified on-call rota. And because they were sharing what are now subspecialty interests, there was enough work to go around to maintain the skills. As soon as you say we have breast surgeons and they just do breast surgery, we have colorectal surgeons and they just do colorectal, the urologists have gone off in a separate tribe many years ago, the vascular surgeons have just split from the general surgeons, then in order to have sufficient tribes and sufficient numbers of people, because you can't just have one in a tribe, it's immediately 3, you've suddenly got 15 consultants on one site for a population of 180,000. Now, if that's the only hospital and that's the catchment and the next one is 70 miles away, well then so be it. But in terms of a dense population of 1.8 million in North West Thames, to raise the standard to the proposed criteria for each of that unit, and I speak for surgery and emergency surgery, is not a sensible proposition, irrespective of money. Now, there may be unintended consequences of stopping the other equally important medical activities. And I prefaced my remarks by crediting what I thought was a wonderful statement from the previous witness. So I'm well aware that I am only talking about a fragment of the totality.
Just to take it a different way around, if we can. I mean, presumably you're saying to have a full range of those different subspecialties in a team to deliver services, you need a certain expanded catchment population. But I'm also right in thinking that if you have that expanded population and these teams working effectively, then you would also need a certain number of beds to go with that in order to ensure that they could actually place their patients for recovery having operated on them.
Absolutely. You need a big resource.
So there's a bit of a trade-off between reconfiguring to reduce numbers of hospitals and numbers of beds, and at the same time bringing catchments together so you get more surgeons.
Sure. So do you, if underlying that question is a very important question, as you can see, I'm very interested in healthcare, a very important question, which is, if you do it better, and by that I mean do it better for surgery, and indeed my colleagues in orthopaedic surgery have an initiative at the moment, which is, the paraphrase of which is get it right first time. So if you do get it right first time, and you have the resources to get it right first time, your question is, do you actually save money? Therefore beds. The answer is probably you do. Whether you do to the extent at which it is necessary to say that you do to make your sums work, I don't know. I'm not an accountant nor a politician.
I mean, it wasn't quite what I was saying. I wasn't actually talking about money. I was talking about the fact that if you reconfigure hospitals to take one out, or in this case take 4 hospitals out of the frame in northwest London, and we are now looking at the plans as drawn up, involve 1,000 fewer beds in northwest London. So if you take those beds out, but you've then got these bigger teams of surgeons able to deliver services, will they have the beds to put the patients in?
I do remember a number of years ago now, there was a joint report, I think it was the Royal College of Surgeons, the BMA and some others, who got together and proposed a much bigger catchment, like 1.5 million, 2 million or something. But they never drew the conclusions as to how big the hospitals needed to be to enable them to actually treat the catchment that they had.
Sure. So it would not be unreasonable to say that you must reprovide the same number of beds that you are currently using, though all of us would suspect that there would be 2 consequences of centralisation. This is a suspicion. The first is that we as surgeons would become more adventurous and we would operate on more people. The second is that probably within that, we would also do it better, right, first time, more senior people, getting to the patient sooner, having made the diagnosis by cross-sectional imaging and not allowing them to languish for 24 hours or over a whole weekend. So we would do it better, but at the same time we probably do more of it. I suspect in terms of beds and resources it would end up as neutral. However, I'm getting a little bit off-piste here, so I must be careful.
Whose piece are we talking about?
Mine.
Could I keep you off-piste then?
Only because you're a friend.
I happen to know you've got a wide experience. Can I be heard?
Yes.
A wide experience beyond the narrow confines you talked about today. Would you mind if I ask you a question based on your previous experience? Because I'd like to explore a little bit of how out of hospital services will maybe reduce admissions, because that is what is one who is meant to believe as part of SHF. And to that end, can I call on your experience? Because I happen to know you were a pioneer of running outreach clinics, which you did without reward, back in a place I know very well, 25 years ago. I remember you telling me at that time you wanted to do it because you wanted to make the decisions as a consultant first. And although we didn't audit it, we did discover that yes, you could probably reduce outpatient attendances by firstly educating us, and secondly because you were making decisions. Now, assuming a consultant is able to make decisions, do you really think the outreach clinics actually prevent admissions? They might prevent outpatient attendance, but they actually prevent admissions. I can give you an example if you want.
It's a very... Am I audible?
Yes.
It's a very, very interesting point. I think the answer to that question is probably yes, because of course you avoid the patients getting into a system which might, I'm being frank here, which might actually do them harm. It might worry them that there is something the matter with them when there isn't. They may be attended to overzealously, or they may not be attended to zealously enough. There might be, once they get out of a consultant-based and indeed primary care-based environment, it may not be quite as safe, contrary to what may be often said. So I believe that using specialists who currently are in secondary care and tertiary care, I believe that using those and being able to cooperate, the cooperation between the secondary, the tertiary and the primary care physicians in the setting of a polyclinic does have a great deal to offer, both in terms of quality, in terms of equity of access, and probably in terms of saving a bit of money.
Can I push you a little bit further then? Unfortunately, I only have a tiny little map, but knowing that you are in contact with the great and good in the profession, I'm trying to understand, when I look at this map, which shows St Mary's at one edge, I know you can't see it, but this is one edge of this great huge area, 2 million people, really on the periphery. I'm told, half a mile away from UCH, which probably duplicates lots of what St Mary's does, except for the major trauma centre, including, we've heard, down to having an HASU unit. Wouldn't it make more sense, having regard to the fact that but for the one ward in Paddington, the most deprived, the most unequipped people are to the west of North West Thames? Wouldn't it make more sense to have your major centre somewhere in the middle, or at least a little bit away over, perhaps, if not in Ealing, where geographically it might make sense, at least in Charing Cross, where it already is or has been? And if so, why is it gone to St Mary's?
So the last bit, I can't really answer. I really don't know. The first bit about what might have been perceived to be the most useful central location. It's my view that the perception of the board probably was, I wasn't influencing this at all, because I did have to be very careful not to be partial, because I was there as representing another body. I wasn't there as a consultant from Imperial. But it was my perception that they probably thought that that central location for all services and emergencies would be West Middlesex. That was my impression. Now, why not the Charing Cross? Well, crikey, it's supposed to have been falling down due to concrete rot for the last 30 years. The paediatrics and the maternity, the obstetric services, not there at all at Chelsea Westminster, proposed to be another central unit. So you could say that it was, the Charing Cross site was terminally disadvantaged before any further discussion went on.
Can I push you further? I've been told by a correspondent that Hammersmith Hospital was seriously considered. For example, that had medical expertise, certainly. It had good buildings, and it had land, and would not be owned by the NHS, and if not, contiguous land which could be acquired, as opposed to St Mary's, which has difficult transport links, old buildings, etc. In your experience in medical politics, do you know what happened to that Hammersmith proposal?
I do know that the original can you hear? I do know that the original Hammersmith proposal was actually many years ago, when I did have something to do with the disposition of services. This is long before Shaping a Healthier Future. This is 15 years ago. And indeed there was a very comprehensive plan drawn up by the old Hammersmith Hospitals Trust, as was, to redevelop the Hammersmith Hospital site, including a station, including a separate slip road from the A40, extensive car parking, all kinds of things, shops, gyms, swimming pools. This was in the heady days before the crash, I think. So there was certainly that plan. What happened to it, I don't know. Part of it, the first part of it, I think, was to develop the renal unit on the Hammersmith site, the dialysis unit, which, of course, has been very successful. But I don't know, Steve.
I have to keep an eye on the clock, I'm afraid, because there's probably at least 2 other witnesses. So may I thank you very much for your attendance.
It's a pleasure.